Pankaj sir, we will be joining the session soon as soon as we finish the previous session because there's still more 2 minutes to go.
Hello, Saichiro. Good evening. How are you? You can unmute yourself. Yeah, hi.
Yes. Good evening.
Good to see
Oh,
you.
good
Uh,
to see you. Congratulations on your nice case.
thank you. Thank you. We are missing you here this time in person. Yeah.
Okay. So in this session, are you going to introduce a counter attraction clip
Right.
yourself? Okay.
No. I'm not going to do anything. I'll just ask a few questions, and I will ask you to show you the video, show the counter traction clip, and everything. So you be prepared with your retract. You gave a good talk in the afternoon, na? So probably
Okay.
from that you can show a few clips and
Mhm.
tell them,
I
right?
see. And
So couple of
I wanna introduce or discuss some other traction devices.
yes. So I will ask you, and so you, Moin, and Gaurav, one by one.
Ah,
So half an
I
hour we will see as many as we can, right?
I see. Okay.
So if you have a couple of devices, I have asked Gaurav also. Moen hasn't replied to me, so I don't know. But probably he will join, so we'll ask him a couple of questions.
I see.
Right. So it's just a very informal discussion and teaching,
Hmm.
right? We don't want to make it very formal.
I
So things
see.
that
Okay.
what would you use in esophagus so, and in stomach? So probably you can show a couple of devices and tell them how we can use it. Then one or two videos Gaurav will also show. Make it brief, and in half an hour we can finish it. That is how.
Hi, sir.
Hi
I
Gaurav, good
All right.
afternoon, good evening.
see.
Yeah, I'm just changing my background. This is from the Endocon meeting.
Right.
Uh, Trying to find any idea how do I go to settings because
You have to go in videos, I think. Stop the video file, just click on
oh,
that,
video setting. Okay, I got it.
and then you can choose virtual background.
Okay. Background and filters, none. Okay. I think that's done. Hi, sir. Hi, Shichiro. Hi.
Hi. Hi.
So Avni,
So we just have, I think, three of us, and Avni is a co-host.
so probably this is because it's between us. Yeah, yeah,
I think it's a split session with.
yeah.
Yes, sir, we can start. We all are here.
Right. Okay. And tell
We are
me if there are a few people who
ready.
have joined this session already. Avni?
Yes, sir.
Yeah. We are listening to some other sound. What is it? Okay, that's probably that
Auditorium.
auditorium. Yeah, she is there in the auditorium. That is why. I think we can start. Yeah,
Only
1 minute.
Dr. Moin has not joined
Only your voice is breaking.
to us, and
Avni, your voice
rest
is.
all have joined.
Avni, we could not hear whatever you have said.
I think she's muted herself, sir.
Okay. Actually, we don't have Dr. Moin Kashyap joined yet.
Hmm.
So meanwhile, we can start.
Okay. Sure. It's already 6:10. So I think we'll make a move. We will make a start. Uh, Good evening to everyone. And today we have Professor Saichiro Abe and Dr. Gaurav Patil from BITS and Dr. Saichiro from National Cancer Center, Japan. And we will be discussing a few tricks and techniques of retraction during in ESD. So if you have any questions, you can put them in the chat box and we'll see that we can answer them in this half an hour. To set the ball rolling, I will just start by asking a few questions and maybe uh, Professor Saichiro can answer. The first question, can you see my screen, na, everyone?
Yeah, yeah, we can
Okay,
see.
Okay.
right. So, Professor Saichiro, can we start with you telling us what is the importance of traction in ESD? And do you think we really need ESD? And compulsorily, what are the indications where we do use retraction devices?
Okay. For for me, the importance of the traction in the ESD is obviously the exposure of the submucosal dissection plane. So, and thanks to the better exposure of the dissection plane, we can reduce the ESD procedure time. Not only the procedure time, but also that we can reduce the risk of perforation. This is the benefits of the traction devices.
Right. So, do you think you have to use it in all cases, or there are some situations where it is better to use a retraction device? Majority of the cases probably you can do without a retraction.
Okay, that's really up to the organ and location of the tumor. In
Right.
terms of the esophagus, the randomized control trial shows the superiority of the traction-assisted ESD compared with the conventional ESD. So for the esophagus, we always use a clip line traction for almost all esophageal ESD.
That's the good,
Yes.
great. Okay. Right. So for esophageal, it is imperative to use. I was going to ask this to Moen, but anyone, Gaurav or Professor Saichiro, you can answer. As you said, you have data for esophagus, but any data for colon or the rectum for ESD traction devices versus no traction devices?
Yes,
For
I think
colon, okay, you can answer. Go ahead,
I think
please.
the first data that was published was for the gastric ESDs, the randomized trial for gastric ESDs in 2018, where they showed that using traction reduced the operative time for almost 50%, which reduced risk of bleeding and perforation, and then also in the esophagus and the colon. But majority the data was for the gastric component. So stomach being the nature of the organ being like a bag, it's not always easy to do ESDs when lesions are on the gravity side. So whatever data we have is more for the stomach and the esophagus. What do you think, Chiro?
Oh yeah, for esophagus, we have a few randomized control trials, and all of them show the superiority of traction assisted ESD. For the stomach, the results are controversial. For creep-line traction, unfortunately, the randomized controls did not show the superiority, as you said. For the counter-traction devices, Nagata et al. Showed that the traction assisted ESD significantly shortened the procedure time. And also, there are some randomized control trial regarding the colorectal ESD for using the counter-traction devices.
Okay.
Some randomized control data shows the superiority.
Right. Gaurav, what are the traction methods in esophageal ESD? Which is more preferred? Would you use a clip and line, tunneling, or any other? So first, I think Gaurav, you take it, and then Professor Saichiro will answer.
Yeah, I think in the esophageal ESD, if you have a good background of performing tunneling ESD or POEM, then tunneling itself can help in giving you traction, because if especially lesions which are on the anterior wall of the esophagus, where because of the scope pressure, there is good traction maintained in the submucosa, and you can cut along in the anterior. Some lesions which are fibrotic on the posterior or the lateral walls, clip line technique can be very well applied to perform quicker and safer ESDs.
Right. Professor Saichiro, this is, I think, from your article, which has been published. I took this table from there. So could you elaborate on it? Can you just explain clip-in line versus tunneling in esophagus?
Yes, also number 2, Koike et al. Is a randomized control trial regarding the clip-line traction. The number of the cases is small, but this randomized control data shows the superiority of the clip-line traction. After the retrospective studies, there are some selection biases, so the randomized control trials warranted to show the superiority, particularly the tunneling technique. There is no data in the randomized control trial.
Right.
So the Japanese guideline recommends you to use the clip-line
Clip-in
traction.
line. Perfect. Okay.
Yes.
So that is a good take-home message, that in esophagus it is better to use a clip-in line rather than tunneling. So can you have some video or something, Saichiro, which you can share for the esophagus? Or you can explain how we go ahead with the clip-in line?
Okay, so maybe you are not. I'm not allowed to share the slide.
Okay, I'll just stop sharing my slide, so you can share now.
Can you share, Shichiro?
You can share it now. You can share it now. Yeah, perfect.
Okay.
Right.
Okay.
So you can just explain how you do a clip-in line and.
Now, can you see my slide?
Yes, we can see.
Okay. As you can see, the clip is line is attached to the backside of the specimen, and then we are going to pull the line. By doing so, the submucosal space is obviously exposed, and following the submucosal dissection is very easy. So as you can see that we can invariably obtain the sufficient traction proximally, regardless of lesion size and location. And we can also maintain the sufficient traction until the end of the procedure, particularly in the distal end. This is the most important benefit of clip line traction. Thank you.
Right. Great.
So,
Okay.
Shiichiro, I have a question. In esophageal ESDs, where would you have like a 5 centimeter lesion, which is occupying 50% of the circumference? So, where would your traction clip will be attached, and where will be the distal end of the? Would you prefer to use a clip line, and you attach it at the proximal end, and then keep on? How much pressure? How do you gauge the pressure of the?
Okay. So it is very important to pull the line gently by your hand. So if you pull too much, of course, please end clip is going to come off. So that it is very important to pull gently.
And which clip do you prefer to use? Because what we have seen in our experience that if you try to use the Olympus clips, they are a little flimsy, so they will just come out very easily when you apply traction. So, any recommendation for the clip to be used?
I think that either end clip is fine, as
Okay.
you can, as you like.
Okay. Okay. So, this is again an example of using a clip-in line technique.
Yes.
So we have already discussed. And now, can you, Saichiro, tell about a tunneling technique in the esophagus? Is it useful? Do you always use, if it is a long lesion, can we use a tunneling first and then probably at the end go and apply a clip at one point? What do you suggest? Or use tunneling with gravity?
In my opinion, the tunneling ESD can be recommended for the entire circumferential esophageal ESD.
Right.
Yes, for the semi-circumferential esophageal ESD, it is very important to keep the normal squamous epithelium in order to prevent severe esophageal stricture after ESD. So I do the tunneling technique only for the entire circumferential lesion.
Right. Okay. So this is another good message that tunneling can be used in esophagus when you have circumferential lesion. Gaurav, anything to add?
Yeah, I think that was the message. So, do you prefer to have 2 tunnels or 3 tunnels, or how do you connect the lateral walls? What is your
in a circumferential ESD?
circumferential?
That depends on the you prefer the ESD device. My preferred device is IT knife. IT knife is good at dissecting laterally. So in my procedures, only one tunnel, single tunnel is good enough. But however, if you prefer using the needle type device, somebody prefer the multiple tunnel, 2 tunnels or 3 tunnels.
So whenever you use a tunnel, you start on the oral side and then go down, or you put a distal incision first and then make a tunnel from above.
Exactly. Yes.
You start from the oral side.
Oral side, yes.
Right.
Oral side and distal side, and then I'm going to create a tunnel.
Okay.
Right. Dr. Kashab has joined us. Hi, Moin.
Hey, everyone.
Yeah, hi. How are you,
Moin? How are you?
Good to see you.
Sorry, I didn't know I was supposed to be here. Good to see everybody.
Yeah, pleasure seeing you. So we were just discussing about the ESD in the esophagus. And this is a question now which I asked, that if you make a tunnel, can the initial incision be on the oral side? What do you say, Moyan? In esophageal ESD, when you have a circumferential long ESD. So you you make a distal incision first, or you can have an oral incision first?
Oral incision for sure, but the so oral incision, distal incision, you keep the lateral margins, of course, and then you tunnel. But important to have the distal incision. I think Abby was mentioning that, but because I think it can become harder later. So I think it's nice to have the distal incision initially. But of course, you have to keep the lateral mucosa intact to be able to tunnel.
Right. Great.
But again, I've only used this for circumferential squamous cell cancer, where I do multiple tunnels, 2, 3, 4 tunnels, and then connect them.
Okay. Right. Yeah. So I think that's a good learning point. So tunneling is confirmed used only for a circumferential long ESDs in esophagus. And what is the final verdict? So that is the final verdict. It's already out now in stomach. Saichiro, what are the recommended methods, or what is your choice? What would you use out of all this? Clip in line, double scope, band, counter traction clip, or tunneling. So we'll start with you first, and then go on to
Thank
Moin
you
and
so much.
Gaurav.
Yes.
Yeah.
As you introduced, several traction devices are developed and commercially available. But I personally use only two methods, the clip and line and the counter traction clip, because the cease-assisted double channel elastic band is not so effective, and also a procedure itself is so complicated. So I personally use the clip line and counter traction clip.
Yeah, Moin, what will be your preference?
Typically clip and line because of simplicity.
Right. And again, I asked a question to Saichiro and Gaurav before you joined, that any choice of the clip when you are doing a gastric ESD, because sometimes which clip do you prefer, which would stay on that lesion for some time and you can apply a good traction with that? So do you have any choice or any Olympus?
Go ahead.
Abby, please. Abby, you're the ESD master. Please go ahead.
Thank you. I think the either end clip is fine.
Okay.
As you like. Yes.
Right. Yeah. So
yeah, I mean, we just use whatever you use. You know, you don't need a special clip for this.
Okay.
So any clip you have on your counter, you just use it.
Right. Okay. So
I have a question. When you apply
Gaurav, you can
in the stomach, especially when there's a fibrotic tissue and you're trying to give a traction. So how much of the lesions you want to cover the mucosa and with some submucosal tissue, or how much of the lesion do you want to dissect deeper and get more deeper submucosa? So how do you decide how much of the clip, how much of the lesion should you be clipping? How deep you should be clipping?
Oh, I think so. It is very important to firmly deploy the endo clip to the specimen. And also the most important point is to keep the optimal dissection plane during gastric ESD. By doing so, you can enter the submucosal dissection plane, and also the I would say the optimal dissection plane is just above the muscle layer.
Just above the muscle.
Yes. As you can see, yes.
Yeah, we can see in that image. So what happens is we often use a clip when it's like a salvage therapy when there's too much of fibrosis, and at that point you don't know at what level is the submucosa and the muscle. So in such areas, you've already dissected the lesion and you've entered, fibrotic tissue in the middle of the lesion. So at that point of time, it becomes, like you'll have to come back to the edge of the lesion, apply the clip, and then begin your ESD again.
Right.
Yes. Right.
Gaurav, can you just highlight any of these devices which you have used?
So a rubber band is something which we have used quite common, and it's quite easily available. So we use the ordinary rubber band. It's a very, the ones which we routinely use.
Okay.
And there is
basically, So basically that principle is the same, that you apply to the edge and apply the other end to the opposite wall.
Yeah.
Now, Mohan, can you tell me, when you do this traction on the opposite wall, where would you apply? See, you can see in this figure they have applied a little proximally. So, is there any choice when on the opposite wall where you would apply exactly at 90 degrees, or maybe a little proximal or towards the antrum? So, or maybe it depends on the site of the lesion. How do you decide where do you apply on the opposite?
I don't have a rule, but you kind of do a trial and error. And see how the lesion is moving. And occasionally we've done more than one traction line.
Right.
So I think it differs in for different lesions. But I think the rubber is nice, the rubber band, because it's dynamic. It continues to, the more you cut, the more tractions you're going to have, because it's rubber. So I think it's a nice idea to use it. I don't know if Abby does use the rubber band.
I think he just told that he is using only the counter traction clip and clip in line. Right. So
a single or a double rubber band. Do you use like 2 bands, and sometimes for larger lesions, especially in the colon or elsewhere?
Yeah, I mean, we've used multiple traction lines for larger lesions, and you know what happens sometimes when you have traction, then the lesion becomes asymmetric. Actually, it can kind of fold on you, becomes difficult, and to make it more symmetric, then you go and have another traction line. So not necessarily you start with 2, but during dissection you apply another traction line.
right. So, Saichiro, coming back to you, this is your baby here, your counter traction clip. So, can you just please explain in briefly? I'll stop my sharing if you want to show. Okay. Right.
Okay.
Right.
Can I explain? Can I explain the counter traction clip?
Yes. Please go ahead and explain us
okay.
the counter traction clip.
Okay, I see. I can skip some slide. Okay, can you see my slide?
Yeah.
Okay, the counter traction clip is developed by Xeon company in Japan. The SO clip, so-called SO clip in Japan. The SO clip is a clip attached to the ring, spring-loaded ring. The clip is deployed to the edge of the specimen, and then a ring of the other side is anchored to the opposite side of the lumen by the another end clip. By doing so, the extended spring provides a sufficient traction. The advantage of the SO clip is, as Moen said, multi-directional the traction. So we can change the traction direction during the procedure. Okay.
Okay, so you can change the direction.
Yes.
Okay.
That clip, I don't think it's available outside Japan.
But
the SO clip.
It will be commercially available in India and some other Asian countries.
I think, yeah, we have started getting it recently, launched by the Xeon company here. Right, so this is the video you shared to me, and this is, I think, another video. If you want me to run it a little, yeah, I think we showed both these videos, right? Saichiro, this is your video. You just shared with me, yeah.
Yes, during the submucosal dissection, we see the severe submucosal fibrosis, and then we use the counter traction clip.
Right.
Firstly, we apply the endo clip to the edge of the specimen, and then we catch the ring and deliver to the distal side and deploy it, anchor to the opposite side using the another endo clip. By doing so, the fibrotic area is well exposed, and following submucosal dissection is very easy.
Right.
But the lesion is located just on the colorectal fold, and the final procedure will be very challenging. Actually, this video case is published in Endoscopy e-video.
Right.
So that, yes, so now we are removing the SO clip and then
applying on other margin.
Yes.
Changing the direction as you told.
Changing the direction to the proximal side.
Right, okay. So that's quite a nice demonstration.
Yes.
Great.
So you mean with one clip you can have multiple, one device you can have multiple areas of traction?
Exactly. Yes.
Okay. Right. So we move ahead. and in colon and rectum. Moin, can you elaborate what would you do for colorectal ESD? Clip-in line, pocket creation, double scope, or any other choice? And
So
when?
my experience in the colon is for the most part strict to the rectum, and I almost totally moved to pocket creation, and it's possible most of the time. So the difference is that I go much quicker that way.
Right.
I don't have experience with the pocket creation method in the proximal colon. Maybe you guys can talk about that, but I will say experience has been pretty good in the rectum and makes it much faster, in my opinion.
Right, I agree with that.
I agree.
Yeah, Gaurav, you have any other option or any choice?
I think single or multiple, depending on how how wide the tumor. These LSTs in the rectum can be extremely wide and almost occupying half the circumference. They can have a large mixed nodular component, so they are like heavy and they start falling on the submucosal side. So creating single, double, or even sometimes 2 or 3 tunnels can help with gravity assisted, obviously. So most of the time in the rectum, pocket creation, as Moin said, works well. About the colon, I think Chiro, you may want to.
Yeah, Saichiro, if a lesion is in the proximal colon, maybe right colon, ascending colon, what if you read traction there, what would you use?
Well,
Because
yes,
I,
we have two options. One is a
right,
pocket creation method, as Moing said. A randomized control trial shows the superiority of the pocket creation method. PCM significantly reduce the procedure time. And also another other option is a SO clip. SO clip can be utilized anywhere you want to do. Even for the proximal colon, we can use the clip plane traction, and we can select the optimal direction during the procedure. Of course, we can change even
Abhi,
during the
what
procedure.
scope do you use if you're doing pocket creation in the proximal colon? Do you use a special scope for that, or do you use an enteroscope, or do you use a peds colonoscope?
We normally use a pediatric colonoscope, pediatric therapeutic colonoscope, and the middle length therapeutic pediatric colonoscope.
Okay.
Nothing special.
it's not a very long, it's a medium length pediatric colonoscope. And that, but SO line, the SO clip or the rubber band would be a better option in the right colon. That is what I presume. And that is what probably is because otherwise clip-in line in that area, you could take the whole thing there and then apply traction, doesn't make any sense. But pocket creation or one of the internal retraction devices would be the choice in the right colon or proximal colon. Right. So this is again a few examples which have already been shown. Before we, because I think we have a couple of minutes more left, Moin, traction versus no traction. Your take on that.
My mindset is you try without traction and difficult position, submucosal fibrosis, then you individualize the case. The pocket creation, of course, has changed things where you don't need the traction. But the mindset is no traction to start with, and use it as needed. Pocket creation whenever possible.
Right. Gaurav?
I think I believe in the same lines. Wherever possible, because of the advantage of starting with pocket creation, you can try and tunnel as much as you can, and whenever as a rescue therapy, as a rescue, you can use traction.
Because
So
here we were not discussing anything about gravity.
yeah,
So I think gravity and this pocket creation, majority of the cases would work using these two techniques. What do you say, Saichiro? What is you practice traction in all the cases that you do, or you have a similar mindset that if you can do without a traction, you will first do without traction? and then use it where we definitely have to use it, where with, as Moin and Gaurav said, with fibrosis or when it's a difficult position.
For stomach and the colon, yes, I'm going to perform the ESD with traction as necessary, if necessary. And for the esophagus, I always use a clip lifeline.
Okay.
All cases.
So right. Okay. So Gaurav or Moin, if you have any short videos, if you can share, if you want to just show them a couple of cases, if you have, just to finish off, and then probably we can sign off because we have 2 minutes left.
Yeah, I think you've shown majority.
I don't have anything ready, so you guys.
Okay. So Gaurav, if you have something to show, just share it and.
Yeah. Okay. I just have one video. I mean.
Yeah, because it's already 6:38, and then we have to sign off at 6:40.
Can you see the video?
Yeah, we are seeing it.
Yeah, so this is one of the this was an inflammatory fibroid polyp in the antrum just proximal, and
yeah, that's a rubber band you are using.
Yeah, we used the Medora clips and try to get traction. This was just one video. This was a
right. Great. Meanwhile, Moin, in rectum and Saichiro, both of you can take this. When you have a very bulky lesion, that is my experience. Below that bulky lesion, there is severe fibrosis. And sometimes it gives you a real headache to dissect that when you are doing an EAD. So what are your tricks? How do you manage those type of cases? Moin, you can go first.
Yeah, you're right. I mean, a lot of submucosal fibrosis and a lot of vessels. Yes. And that prolongs procedure time. We always say rectum, if you want to start ESD, this is where you want to start. And that's because of the safety net, right? The retroperitoneal space and the thick muscle. But I really think it's not that easy. I mean, the complication rate is less, but the procedure itself with the huge vessels and the submucosal fibrosis makes it difficult, kind of slows you down. But when you get into that business, that's just part of the game, and I've seen Abby doing 7-8 hour cases of rectal ESDs with a lot of fibrosis and vasculature. Even for somebody experienced like him, it can be tough.
Right. So probably those are the cases. So last words from Saichiro. In such difficult situations, large bulky rectal tumors with severe fibrosis, your advice?
I personally think it is a limitation of the ESD because not only submucosa but also the muscle layer is retracted to the lineal side.
Yeah, so that becomes very difficult. You don't know whether you are cutting fibrosis or you are cutting muscle sometimes.
Exactly.
You will end up
according to our data, the umbilical resection is not so high, and also the many of them invade the deep submucosa. So I think that is a limitation of the ESD. So given the big lesion size and technical difficulty, I think the laparoscopic surgery is one of the options.
Right, laparoscopic surgery, or maybe if it is distal rectum, you can use the TEMS.
Transanal,
For lower rectum, of course, we can dissect the muscle layer, but for colon and proximal colon, we cannot do that.
Right. Perfect. So I think time is up, and thank you, Saichiro, Gaurav, and Moin. Good to see you all, and hope to see you in person sometime soon, wherever.
Yes.
Thank you so much for joining us.
Thank you so much.
Thanks a lot.
Good to see you guys. Bye-bye.
Thank you.
Bye. Good day.
See you. Bye-bye.